because you cannot invest 200 crores to create a 200 bed facility year after year, but you can optimally use that year after year by being smart in reducing the average length of stay and improving your average revenue per bed. Last part is the social perception. I want to highlight two broad elements here. We talked about how people behave when they are there in their homes, but I think there is a huge problem with our medical fraternity. Our medical fraternity has not accepted home health care as a natural extension of care. This is a bigger barrier, and it's exactly the same barrier I faced when we started emergency medicine. Everybody said, who are you? You're a casualty medical officer. How can you intubate? How can you put a central line? Right? So these are barriers which are very difficult to cross. And it's very evident when we do business. In the last 3 years, we've handled close to about 75,000 cases. On a given day, we handle about 250 patients in 5 different cities. People are in desperate need. They reach out to you any which way. But I think what is important is for healthcare providers to understand that we are not taking, home healthcare is never going to take away their inherent business or revenue stream. It is a way to optimally use your time, not spend on minor things. How a busy orthopedic surgeon comes down to the casualty to do a plaster cutting and changing. Does it happen in your facilities, yes or no? No? He sends a resident or registrar because it's a big institution. But otherwise, you see orthopedicians making patients wait for 3 hours to just remove a plaster cast in good institutions. So, yeah? All right. So I think there are 2 levels in which there are perception things. One is the healthcare community, which I feel is a bigger challenge. And on the community front, there are a lot of challenges in terms of what they expect. Their expectation is a better substitute for a maid. Honestly. As madam was saying, there are people who say, sir, 600 rupees mein tracheostomy ka bhi kara dijiye. They start by saying this, okay, humko aid chahiye, fir uske baad mein they'll come down and say, sir, अच्छे सर उससे सिखा दीजिए ना 2 दिन में. So I think this is a long drawn journey. I think it's too early for us to get conclusions in this. These are challenges we'll have to face, but what is important in this battle is we need to create good exemplary home healthcare organizations in the country. What sadly is happening is majority of the players are unorganized, unaccountable. Then there are at the other end large players that have come in who sometimes have lesser emphasis on the clinical care, more emphasis on the technology part of the whole story. I think this is where if we converge, keep patient as the primary focus, patient care, patient comfort, patient safety, and patient outcomes as the fundamental goals, we will be able to create right standards, right accreditation process, and right outcomes for our patients. Thank you so much. That must have been less than my time.
Thank you, Dr. Joshi. Excellent presentation. Now may I request the last speaker, Mr. Sandeep Oberoi, General Manager, Philips Home Care.
Hi, good afternoon, everyone. And on behalf of Philips, I welcome you all to this session. At the onset, I would like to thank Symbiosis for featuring this on the panel discussion, which is the home healthcare. So let me start with myself, that I've been with Philips for about 10 years. So my perception was that's the most exciting opportunity I've ever got when we started the home care in September. And echoing to what Dr. Joshi has mentioned, that yes, now we are facing the reality after 6 to 8 months at how difficult it is to bridge the gap from a potential to actually realize value, which would make a difference to patients' life and also which would be a value creator for the company. So why do we talk about home healthcare? And this is one thing which I have, read in the management to present and, think differently. So I presented some of the earlier presenters what they've done in a different format. So this is an overall opportunity or overall potential, which also further amplified the perception about the excitement which I had, before I joined the organization. So this was about a $2 billion opportunity as a potential. And I've further also classified this into different other care areas, which could be, sleep, respiratory, could be, oncology, and so on. And if you look at this from a value-wise, more than 50% fall in the area of sleep, respiratory, cardiology, and oncology. So these are the 4 critical areas to be addressed to out of the $2 billion of opportunity. And being a commercial organization, we, looked at that this would be an interesting space to be in, and this was an easy win, and then we looked at sleep and respiratory as our primary choice. But I would like to also highlight that how do we classify, because, there are different type of home care companies. Dr. Joshi also mentioned that, there are people who are technology-based, the people who are more resource-intensive, the people who are skilled, unskilled, and so on. And one of the way to classify the home care companies as such is the companies which would come with a high touch and low tech. And when I mean high touch, low tech type of organization are the one which provide nursing services, physio services, physician services, and maybe a device could be used as an enabler as and when required. So there are a whole lot of companies in that space, and they're primarily into healthcare delivery side. Secondly, there are companies which focuses on high-tech, low-touch, companies like Philips, in which they don't provide independent of nursing or the doctor services, but whenever it is being required by the patient, they would provide it. Like, for example, if there's a ventilator-dependent patient, we do provide the nursing services. So there are 2 different type of companies to look at, and what I'm going to talk about, the challenges is not generic, but challenges which we feel as a high-tech and a low-touch company. There would be some challenges which would be common in terms of resources availability, in terms of training, but there would be certain things which will be very specific to the equipment organization. So this is what we do. We collaborate with the healthcare delivery providers. We always believe that there is nothing which we can do it alone. So we collaborate with the healthcare delivery providers, whether it is a hospital or the physician, to provide, the disease management program for our patient, in which we do our piece in terms of providing the devices, the paramedic support, and the technology, which becomes an interface between the physician as well as the treating physician as well as with the patient. And of course, we collaborate with the healthcare delivery providers or individual physicians to give us the patient flow and tell us that what needs to be done, because we are there at the execution level and provide the information or close the feedback loop coming back to them. In terms of what are the challenges? So there are 2 sets of challenges. One is pre-joining the home care and one is post-joining the home care. So I will first talk about the pre-joining the home care challenges. So these are some of the syndicate research which we did before getting into the home care. Some of them are really true and some of them stays to be validated. Some of them are not. Like, for example, the very first challenge which we looked at is the absence of aggregator. And here, by aggregator, we're not looking at somebody who will aggregate all the services and give it to the patient. This aggregator, like in the US or maybe some of the experienced people who worked in Western world, where the physician nor the insurance plays the role of an aggregator and provide these type of services, or the hospital institute provide these services. Unlike that in India, the patient ends up to be an aggregator. That is the pre-start of it. But now we have a lot of aggregators who have actually mushroomed up to provide these type of services. So this is one issue, and there is no aggregator being present. Of course, you have the lack of affordability because nobody has economies of scale, nobody has the bargaining power, and then you make it very unaffordable for the patient. That is only affordable to the richest of the rich. The third one is, of course, in terms of equipment space, this is largely being dominant till now, being with a small time of local, distributors or channel partners, for which the physician feel that, of course, by offering a chronic disease management, which also includes the device, will be incompetent to execute that. So that there is a lack of trust because they feel that they're incompetent to overall manage the care, and this care which includes the quality of life, which includes reduced hospitalization, and which includes the proactive clinical intervention. So they say they may be good in providing the devices, but may not be overall holistically manage the disease. Last but not the least, that's a common problem which we all face. All the eminent panelists have also spoken about it, that the skilled, manpower. So where there's a dearth of good, the healthcare workers in the healthcare delivery industry, of course, the home care industry faces even a bigger challenge. One of the programs which we run, for which we have about 1,200 plus patients, that requires primarily the respiratory therapist to go and execute this care plan. and there are only 2 institutes in the country who run this program in an undergrad level. One is Manipal, and of course the second is Symbiosis. So these are some of the challenges what we face, and these are the challenges which we are facing. Imagine in the top metro city which we operate in, but if we go into tier 2, tier 3 cities, the challenges will be more. So we've also looked at some of the, we have classified the patient into different age groups, and we've looked at what are the pain points. So these are some of the challenges coming from the patients for being treated in the hospital and wanted to get into the home care. So why did they first being motivated to go for a home care? So there were different level of motivation across the different age group, and I will be very honest to say that majority of our patient has been more than 65 years of age. So our median age is close to about 64, 65 years of age. So majority of our patient is over 65 years. And there are 2 prominent things which, bothers them, for which, tell them to go and motivate to adopt to these services. One is, of course, the affordability. And everybody's spoken about insurance. Majority of the patient, what we have actually taken on our program, are being self-paid. So they are the one who pay out-of-pocket expenses. Some of them have the insurance cover, but it is not enough for them to get treated for the complete disease management. So this is the first challenge they face. The second challenge they face is, if you are in a chronic disease management, if it is irreversible, you get frustrated because even with the best of the care being provided, you can only manage the disease. You cannot reverse the disease. So that's another frustrating factor which this age group faces. Third is, being treated away from the home. So they're also conscious to the fact that when they're getting treated in the hospital, they have the whole family, the whole family contributes the time. So there's a time loss of the working class as well. So they're also sensitive to the fact and starts to get the feeling that they're becoming burdened on the family because they're non-working, and also the working class is, contributing enough of the time. So these were some of the pain points which they had, which, motivated them to get into the home care services. Then we also looked at, of course, they have this pain points, but to motivate them, there are some perceivable benefits which they say to adopt to these services, but there are some concerns, and the concerns are largely towards the expert care. Whether we get a care by a doctor at home or not, whether we used to getting a phone call care from a doctor, shall we call him, rather than being treated by a skilled or an unskilled professional at home, number one. Number two, what happens in the case of emergency, whether the nurse will arrive on time, whether the ambulance will arrive on time. All these challenges are not being faced when they are there in the hospital. So the lack of the expert care and the fear of death are the 2 primary reasons which are a big area of concerns, apart from being affordability, of course, which is a common across the whole group. We also looked at of course, Dr. Joshi has spoken about standardization, accreditation, and the legal. And we also share the same point that, legal is a big gray area. Our understanding is at the same level as what he also mentioned. But in terms of standardization and accreditation, let's go back to the basic that what is standardization? So standardization is development and implementation of some of the protocols or SOPs which are there to provide a certain procedure. And they could be the same what has to be implementable either in the hospital or in the home environment. The same set of procedure at a different scale, but the basics remain the same, that you have to provide the best possible practices so that you have the better repeatability, low error, and the desired clinical outcome. So this doesn't, according to me, doesn't change in terms of the standardized care. In terms of accreditation, of course, Dr. Joshi also spoke about NABH. Uncle Google, thanks to him. So JCI launched this accreditation guidelines for home care in 2012. Which largely spoke about two biggest things. One is about the patient safety, so that is one. And I've read through almost most of them, and for the most relevant to the Indian context is assess and provide the counseling. That means when you enroll the patient onto the home care program, tell them that what is the type of care you are providing and what to expect. You cannot tell them that, this will replicate the hospital. If the patient has a higher risk of being rehospitalized, you have to tell them and get them prepared. So that I found to be the most relevant to our Indian condition, though it talks about 10 other things. Second is it talks about the management, what is the standards the management within the home care companies would look at. So Again, there are about 8 or 10, the plethora of activities which needs to be done. The most relevant which I found is staffing. How do you staff them? How do you define them as a critical care nurse or a general nurse or an attendant? How do you evaluate them? And what are the academic credentials? And then how do you evaluate them over a period of time? Whether you build up whatever you've taught them is enough for the life or not. How soon you can bring them back and train them. So these are some of the things. Of course, there is a whole list, but I've been told that the time is up. So without wasting any time, I'll conclude my talk. But overall, it's an exciting journey. Okay, we learn on the way because we are the most. The beautiful part of this industry is we are the one, whether we complain it, whether we say, great things about this, we are the one who's going to set the standards for others to follow. From a Philips perspective, I think this is the first time we're doing it globally. And there has been some excitement across the other part of the world that if we can do the same care at an affordable cost. So it's not only India for India, Dr. Mankar, but we're looking at India for the world. Thank you.
Thank you, Mr. Oberoi. Dr. Mahesh, the empire has struck back. They have cancelled the panel discussion due to paucity of time. So we didn't keep up our run-overs rate. But they have been kind enough to allow 2 questions and answers. That means you can ask 2 questions and we can give 2 answers. Yes, sir.
My question is from Dr. Joshi. As we heard, that India it is very difficult. So can we take home care industry as a business or as a social service? Because attendant required 10,000 to 15,000 for 12 hours. How we can think about nursing assistant, nurse, doctor? So is it a social service segment or business segment?
Hello. If it is your money, I would like to do social service. Taking the joke apart, this is important. See, anything that you do must be sustainable. Right? Whether it is social service or whether you are doing it as a business, it must be sustainable. Right? Let's look at LV Prasad. Let's look at Sri Chitra hospitals or the other, Arvinda Eye Care. What is it, social service or business? What do you rate it? It's a great example of business along with social service with sustainability. Ideal business should be run like that. And anything in healthcare should be run in that manner, that you keep the value system of ethics, patient care and outcomes first. Create systems to sustain it. Otherwise, you don't begin it. That's very important. That's how I look at it. No. They are going hand in hand. Never do this mistake, sir. We always try to take, pretend saints. Let's do social service. Not sustainable.
I think the government has a very big role to play here to uphold the social end of the service by providing some kind of SOPs to businesses which are providing this care. One more question.
Question to Dr. Joshi.
Just 1 minute. He put his hand up first. Who are you addressing this to? Who would like to take it on?
Accountability and liability to everybody else.
I'll take that on. So, accountability and liability of care applies, say in a hospital, there are certain rules. You take the case of Uber, who came and said, we are getting a lot of people together and creating only providing the care. The government, according to me, very rightly said, you can't just get away with that. You have to be accountable. To my mind, it is the company which is accountable. There is just no doubt. Doctors are liable for the care they give if they are working as freelancers or as on contracts. Nurses are not allowed to be on contract in our country as of now. There is nothing like a freelance nurse. She cannot take professional indemnity and practice house to house yet. I think that needs to come through. But even if a company is aggregating nurses and sending them somewhere, if things go wrong, it's the company who's going to be liable and accountable, both.
So it covers the indemnity for the doctor's company.
I think I would like to add one point here, though. If there are two parts of this, like Dr. Joshi also mentioned, that it's a gray area, okay, the legal. And on paper, of course, the roles and responsibilities are very well defined. Physician, respiratory therapist, devices based, and so on. But when it really touches the court, then the law of equity comes. So then the most powerful gets a beating. So.
Thank you, ladies and gentlemen. I wish we could have interacted more, but maybe over a cup of tea if there's something outside. It's been great having you here.
Thank you, speakers, for illuminating our minds with the facts on today's home care scenario. Now I would like to request Dr. Samita Jadhav, Deputy Director, Symbiosis Institute of Health Sciences, to felicitate our speakers.
Thank you, Dr. Samita ma'am.